January's podcast for LLR LMC, and today I'm joined for change by Charlotte Woods. Now, Charlotte Woods is the glue that keeps the LMC together. She's the one that tries to keep me under control and keeps reminding me when I haven't done the work that I'm supposed to have. So Charlotte Woods is the operations manager. So say hello, Charlotte.
Hi, Grant. Thank you for roping me into doing this. I hope our viewers will find it useful and kind of a bit entertaining along the way.
I'm sure our listeners will. So Charlotte's actually going to introduce each item, and then we'll just talk through it.
Okay, thank you, Grant. We've just picked out a few items that we feel will be helpful to go through today. The first one is around the LMC position statement in relation to pathways. Grant, would you mind kindly expanding on kind of what we've written within the newsletter?
Yeah, I mean, it's sad that we have to do this. This is our second position statement. For those of you that have read the newsletter before, know that we recently did one on shared care agreements. This one we've done on local deviation from national pathways. And it's really just setting out what our stall is from the LNC's point of view, what we find acceptable and isn't. The issue we've had is that we've had a lot of pushback from secondary care who want to change local pathways to not be aligned with national NICE pathways. This they're doing, to be honest, to reduce their workload, to reduce their waiting lists, but at the same time, it then basically transfers risk from them across to general practice. Particularly, if there is an adverse event or complaint, bodies like the Parliamentary and Health Service Ombudsman, CQC, GMC, what they do is that they assess whether the GP has followed NICE guidance, and if not, why not? So it's really difficult for them to just for practice. It would be really hard to defend, really.
Thank you, Grant. In relation to from a practice perspective, if they feel that there's they've kind of been requested to kind of divert from away from the national kind of guidance, what would be your message to them?
Yeah, I mean, well, obviously, we've done this thinking about when we've been involved in pathway designs, but we know from time to time that consultants will write to GPs and ask for them to do something which is out with normal expected practice or out with national guidance. If you get that, please TCS it. TCS is our system. I know that some people love it and others absolutely hate it, but it is the system to record these concerns about TCS it, but also let the MSC know. If you don't get a decent response from TCS, then again, just inform the MSC so we can take it up on your behalf.
Thank you. And I think that's all the kind of the direct questions I had in relation to that item. I was just wondering whether we could now move on to the next item, which I think will be useful to discuss, because I know emails have gone out around this, is around the prevention of the sexual harassment guidance. Could you just kind of summarise what that is?
Yeah, I mean, first thing to say is obviously the LMC is absolutely in full support of the prevention of sexual harassment. In an individual capacity, it's something that I've campaigned about in the past repeatedly because of this actually happening within the BMA, which I found absolutely appalling. What's happened is that there was a charter that was done in 2023, but that seems to make no difference. But of course, all the surveys that they've done have been within secondary care and not within general practice. So what you'll receive, if you haven't already, is a self-assessment checklist, advice for staff to complete online training, and to advice to sign the Sexual Safety and Healthcare Organisational Charter, the one that we started in 23. Now, this is a bit different for general practice because, of course, we are much smaller organisations. So some of this feels a bit like overkill. I mean, we've looked at it. We think the self-assessment checklist might be helpful for practice to be aware. Of course, there is a legal requirement under the Equality Act 2010, which now says that an employer must take reasonable steps to prevent sexual harassment of employees in the course of employment. So you are required to do that, and of course the CQC and the ICB may come knocking on your door and ask you how you actually comply with that bit of legislation. But the other bits around this, about whether you need to use their online training that they're suggesting or whether you do it within house, is totally up to you. And also whether you sign up to the charter is up to you. As far as I can find out, and I've done a bit of digging, I cannot find any contractual or other requirement for general practice to sign the charter. Although it wouldn't surprise me, as it's been given so high prominence, that this doesn't come in for next year as a must do in the contract. But at the moment, there isn't a requirement. Although unfortunately for the ICB, they have been given by the requirement from NHS England, the department, that they must ensure that we're doing it. So I don't quite know how they will square that circle. But that's it. So I mean, we support the principle, but I mean, how you actually deliver it within your practice is up to you.
That's really useful, and I think it was the questions that we've kind of already been asked following the communications that's gone out, is whether it's obviously mandatory. But I feel like you covered that within your kind of response, in the sense that obviously practices need to be able to demonstrate that they are covering this kind of area, but how they do it is up to the practice. Is that correct?
Absolutely, yeah.
Thank you. I'm just going to take us on now, kind of swiftly, on a kind of a bit of a different angle. It's around the LMC constitution. This is a kind of an internal document, so around the LMC. We've made some slight changes. Maybe you could just cover them slightly.
Yeah, so constitutions should be living documents. They shouldn't be set in stone. And the MC has been on a bit of a journey. I've been encouraging the MC to make changes to make us more representative, but also bring in succession planning. Hopefully you all know that we did that in the last election. And the constitution actually leaves it up to the board to decide how we run the elections, whatever. But the board have now decided that for some of this stuff, it ought to be actually really set in stone in the constitution, so to sort of guarantee it for the future. That includes things like ensuring that at least 2 elected members are sessional GPs. There's minimum 1 elected member who's within 2 years or less completing their training. As well as the previously agreed, there's got to be 4 from the county, 4 from the city, and 1 from Rutland. We've had a bit of a think, because actually other LMCs had a bit of difficulty getting sessional GPs to stand for MC, but at the last election, and I'll ask Charlotte to actually to remind us actually what the outcome of the last election was. In the last election, we had loads of sessional GPs standing, and we had more than enough elected to fulfil the requirement. So we have to be aware that the MC's work will always mainly be focused, aside from pastoral parts, will mainly be focused on the contract, both the national contracts and how they get implemented, and how they are interpreted locally, but also local contracts. So because of that, the board felt that we should always remain with a majority of the elected GPs being contractors. By contracts, that means named on a GMS, PMS or APMS contract at the time of the election, because obviously people do change. So we are proposing that there should be 6, a minimum of 6 of the 11 must be contractors. So we're adding that in. There's a few other sort of tidying up changes within it. So we've changed executive to chair, which we did before. And we've also changed medical secretary, which was in the constitution from a long time in the past, to chief executive, as we agreed to do before. But other minor things is that what I've also proposed, and the board have accepted, that an EGM should also be allowed to be called, an extraordinary general meeting should also be allowed to be called by a majority of board members, as well as by a majority of constituents. So that means that if the board is unhappy with what the chief exec, what I'm up to, or the chair's up to, or I'm up to in cahoots with Charlotte, then the board can call a meeting to call us to account, which I think is absolutely right and proper. So please read it. Please let us know your comments if you're unhappy. If you've got any other suggestions that we should be doing, come back to us. There's one bit we haven't put in, which is about using single transferable vote, STV. We still plan to do that, but the board felt that actually we should still leave that to the discretion of the board, so that if there was an election which they didn't think could work with STV, then the board actually could change it for that individual election.
That's
So
useful
Charlotte,
summary.
yeah,
That's
do
a
you want
useful
to?
summary, Grant. In relation to, is that so? Those changes that you've mentioned, is that an imminent change, or when does that kind of get ratified?
So most of these changes actually is just a catch up. So we've already got them in place. So it's actually just putting into the constitution what we're already doing. The only new one is about the ability for the board to request the extraordinary general meeting. So the constitution, when I came to the LMC, the constitution actually didn't allow the constitution to be changed. Which made it really difficult to think about how do we do that. And for those of you who remember back that far, about 2018-19, actually we wrote round with a changing constitution and say, can we adopt this to constituents, and within that it allowed us to do it. But the constitution allows for 14 days for comment. So once the LMC newsletter has been sent out, then you get 14 days afterwards for comments, and then it will be ratified at the next LMC board meeting, when if we have had any comments, the board will take those into account.
Thank you. And just to kind of let listeners know that all our corporate documents are stored within and available on our website. So if anybody wants to kind of view them at a later date, they are available. Okay, I'm going to take it on to a slightly different kind of topic now, but this is kind of be the long running topic in relation to BadgerNet. Hopefully people know the kind of the background of it, but I'm going to let Grant kind of touch base on, just give us a brief summary and kind of where we're at, please.
Yeah, so BadgerNet isn't related to digging holes and bringing along nets. It's actually related to the new software that UHL have decided to use for the midwifery service. We had an awful lot of talk with them beforehand about what this would mean, and there are advantages for practices. But what we were unaware is that when they went live without the ability to communicate with practices, which obviously we've raised as being a significant patient safety issue, because it means that practices at the moment, or at that time, were not being told when a patient was pregnant. Now we have asked that they move rapidly on to setting those systems up, but in the meantime that they go back to the previous system of informing practices when a patient is pregnant, however they wish to do that, whether it's logging onto system one and sending a task, or whether it's actually sending an old style letter.
Thank you. And are we at a position that we're finding a resolution for that?
Yeah, so it's there. I mean, the resolution was there before. It's just for some reason that they went live with part of the software without all of it, which to me seems a bit bizarre. There is one bit outstanding, which we're still in discussion with them, which is not really about BadgerNet, which is about prescriptions. So, we consider midwifery exactly the same way as we would consider any other outpatient service, so that if the midwife is advising a practice to prescribe something routinely, then yes, that's reasonable that they send a request through. But if they want something which is non-routine, then the LMC's view very much is that the midwives must have the ability to either prescribe it themselves or otherwise have some sort of process within UHL as how do they actually provide those scripts. Just as a sort of a side routine, we are still pushing on, and they're still saying to us that one of the next new bits of IT they're going to be rolling out is the ability for them to do electronic prescribing. So very soon, all departments within UHL, it will be rolled out department by department, but very soon they will be starting to have the ability to be able to send from outpatients or inpatients or whatever prescriptions directly to community pharmacists, rather than having to say to the patients, if it's a remote call, that they've got to come in from Rutland, say, to get a script issued within the hospital, or instructing, as they like to do, GPs to do their work for them.
Okay, I know Badgernet has been a kind of an area that practitioners have raised directly in relation to kind of any concerns, so it's really good that we kind of have an update on that. If there's any, do you feel there's any further advice we should be giving practitioners if they recognise, because obviously it is a new service, what would be your advice to practitioners if they see any kind of further patient safety risks, or should they notify the LMC, or should they go for a TCS, or how would you say is the best way that they kind of handle any kind of go forward?
I mean, if it seems to be a problem with the way that an individual patient has been handled, that clinician doesn't follow the process, or is asking for something inappropriate within a letter, and by clinician I also include midwives in that, then do TCS it. But if it seems to be that the process is wrong, or it's not working, or it's been delayed, or you've got, you just want to throw the computer out the window, then that should come through to the LMC, please. A lot of our issues, and in fact the next one we're going to talk about, but a lot of the issues we have and we have to sort out has been because a vigilant practice has spotted something going wrong and has come to us and raised it with us. So we have then been able to sort it out, for the benefit of the whole area.
Thank you, Grant. Obviously, that's a kind of an area we've kind of covered before, so it's useful to kind of get that update. In relation to the next bit, I was going to just move us on to was around the duplicate letters that we've kind of highlighted within this newsletter.
Yeah, so
just give me a brief summary.
Yeah, so this is really just to let you know that we know, as it were. So again, this was raised to us by practices, and in fact, I had a joint letter with someone from a federation and the representing several PCNs, and to talk about this, to work out what was going on. We've discussed it with the UHL. With those people with the UHL, and what we know is that practices are getting many duplicate letters dropping into their inbox. There's one practice who outsource all of their document handling and actually say, I mean, it's quite a big practice, but they say it's actually costing about £1,500 a month additional fees just to handle these duplicate letters, as well as it's being, again, it's patient safety risk because it's trying to spot the wood for the trees, and you've got, and if your trees have suddenly become 1,000 more, it makes it a lot more difficult. So we are aware of it. UHL are aware of it. UHL have come back and said, actually, there's more than one thing going wrong. So what they're asking for is actual examples. Now, we've already been sent through several which we've asked UHL to look at and sort out. But rather than saying send us now, but if in a month's time you get more duplicate letters, can you actually send exact the actual letters? Now, what I don't want you to do is to send letters to the LMC, because for the purpose of UK GDPR and the Data Protection Act, we don't have the right to see that unless a patient has given clear consent. But if you contact us, we can then give you who to directly send to at UHL. But I would like to do that rather than give you a link, because actually from the LNC point of view, we really do need a handle on how many of these are coming through still, and where they're going and where they're going to, and that sort of level of detail. But
so when you say the examples, are you kind of referring to if you get two kind of duplicate letters for the same patient, for the same, exactly the same, you want to know which speciality it's coming from and where the letter is coming from, so we can kind of see that and action it accordingly?
Yeah, so if you give us that level of information, and then we will then give you an email address at UHL for you to send it to them. And that address will be different depending upon where's it from and what the possible problem might be.
I think just you covered it within your kind of bit, Grant, but I think it's just important to kind of highlight as well that we support practices on a wide range of issues. It completely varies, But I think it's just a stress that if you have issues, to not send us patient identifiable information, because obviously that is not something we have consent to have unless you've already received consent from the patient. So just a kind of a bit of a plea, really, if you send that information to us, to either get the consent from the patient or block it out before it comes to us, so we can assist you further to take that forward. I'm going to move on now to the sharing of the LPT data. I know this has kind of been a long running thing, and you've kind of put quite a big bit within our newsletter this month. Could you just kind of summarize kind of where we are with this kind of item, please?
Okay, so the first thing to say is that this has been going for at least 8 years. So this was first raised by the MC with the ICP at least 8 years ago. So this is not something that we're coming to, rapidly. This is not something that we're not doing without an awful lot of thought. But practices are being put at risk. So just to describe it, what's happening is that, and this is particularly LPT, and particularly consultants are writing letters. Now, those letters, because they have ability to access System 1, they actually appear on the System 1 electronic patient record, visible from the general practice unit. So you can see it, so you can see the letter there. But of course, unless they then tick the extra box to send the letter to us, although it's visible within the record, we don't actually know it's there unless you stumble across it. Now, of course, that's a patient safety issue because, it can be just sort of some update, but, because we're talking about CAMS, we're talking about adult mental health, this could be a patient that has become mentally, that their mental health has become much more severe or uncontrolled, and or there might be a safeguarding concern which is being raised, but it's in a letter that we cannot see. So I had yet another letter with LPT. The board. The last board meeting resolved that we should actually be advising you to turn this off. I did have one last meeting with LPT just to give them another chance, and they couldn't come up with anything else. Basically, what they said was, and I thought it was a little bit glib, is that we've tried to put things in. In fact, now when a consultant does a letter or clinician does a letter, they actually get a pop-up saying, "Do you want this to send this?" And they actually have to say no for it not to be sent. But despite that, that is what's happening still. So we're still getting practices that tell us that they're still happening because they're still coming across new letters doing that, and that is not acceptable. So that is basically it's transferring risk from the LPT. So in the old days, if say psychiatrists seen a patient and they've forgotten to send a letter, 100% of that risk would have remained with LPT. But by doing this, there is a transfer of some of that risk across to the practice. Now we have gained legal advice, and the legal advice was a little bit reassuring. We said actually that still LPT would still be in the main filing lines, but there is a risk that practice could be named as co-defendants within a claim, but it's also that there's the risk of complaint and sort of how that might undermine your relationship with your patients and reputational damage. It wasn't quite the same, but I did have an issue at my practice where a palliative care nurse had written some guidance for an end-of-life patient and hadn't actually sent the right task. So as a practice, we didn't actually see that it was there. And unfortunately, it was about prescribing more end-of-life drugs to give that patient a sort of a nicer passover, which was missed. And the relative, the daughter, was absolutely incandescent at us. We did a full investigation and presented it, and I presented it to her, our findings, the fact that yes, the palliative care, as she had told the daughter, had actually made a note, but they actually hadn't told us that note was there. But the relative couldn't actually get their head around that and still felt that, as it was written in our record, we should have known it was there and we should have acted on it. even though obviously pragmatically we cannot look through every single patient's record every single day, just in case someone's written something. So to me, this is about risk, but it's also about undermining at times the relationship between us and our patients. So what we're saying now is that we've had enough. We've given them long enough to sort this out. They haven't been able to come up with everything. And on the recent meeting, they were unable to give me any suggestions or anything else that they could do. So what we're suggesting is that you turn off the ability of LPT to write to GP system units. In the newsletter, we've got some screenshots about how you can do that. There's two ways of doing it. One which actually just makes it more annoying for them, and one in terms of. So there's one which is where you can require verification, which means that every time they have a patient that we wish to share, they actually have to ask the patient to provide them with permission to share. So that's one step. So you might wish to do that. But what I think that really we are asking practices to do is actually you just turn off the ability for LPT to share with your GP record. We hope that what this will do is that this will highlight to them that they have got to take this more seriously, that 8 years later, they have got to sort it out. And as soon as they sort it out, we'll be back to you to say, yeah, start sharing it again. But in the meantime, really strongly we suggest that we don't. I mean, if the boot was on the other foot, as it were, if we had a practice and we had a GP within a practice that was constantly ignoring a patient safety issue, first off, I think you'd be hauled up before the ICB performance people. I think you also will probably have complaints going to CQC. And I think as a practice, you'll probably be wanting, if it was a salaried GP at least, you'll be wanting to take them down the disciplinary route. And so why on earth can LPT not do this? I do not comprehend.
I know this has been a very long kind of running factor, sitting on the other end of the kind of behind this desk. It's kind of one of my kind of greatest kind of files within the LMC of an area that we have tried and exhausted kind of all opportunities to resolve. And I think obviously from your perspective, Grant, this is the only kind of option to be able to leverage that change. So I think that's kind of the really helpful kind of summary. In relation, just go back on that bit. I know there's kind of some things around the SARS, and so if a patient accesses you might not know the letter is sitting there, but if a SARS was kind of done.
Oh, absolutely, yeah. So if a SARS was done, if say there was an inquest, or if the ombudsman asked for the records because there had been a complaint that had been escalated to them, absolutely, when they get it, all they will see is that entry within the record.
Yeah, I'm glad we kind of clarified that, because you were looking at me a bit like I've gone out, so I'm hoping.
I thought we were talking about stars. I thought we were moving on to astrology.
Oh, stars! Sorry, I feel like I need to cough, so apologies. No, we're talking about SARS, unfortunately, which is another kind of a technical element, but that's really useful. I'm now going to just kind of move us on slightly in relation to another element, which is the Child Health Information Service, which is the CHIS, which we've seen some kind of changes in relation to that recently, which practices have reported to the LMC.
Yeah, now, as I keep telling my colleagues, I do have a series of circles on the brick wall behind me that I like to go and hit my head against. And this is one of these that I've got to that stage. So going back to much earlier in the year, this was being talked about aligning.
You mean last year? We're only in January.
I do mean last year. Yeah. So aligning all of the different ways. So I understand that there was 4 different ways that practices had their patients, children invited for routine vaccinations, and for quite clear reasons. The NHS England wanted to align those to one process across the whole of the area, which seems really worthwhile. But we had some concerns raised. So I met with them in August and said at the end of the day, it's their decision, but they've got to do this properly. There's a lot of concern that by doing this, they're going to be undermining quite mature processes that practice would have had in for many, many years. And so there's a risk of even in the short term, of a reduction even in vaccine uptake as practice get used to it. But they also would need to have time to develop their own processes, to put training in place. So that's where we were in August. The other thing we agreed at that meeting was that it would be a phased rollout, starting with 12 volunteer practices, and that they'll be learning from the experiences of those 12 before rolling it out to other practices. We hadn't received anything more. The NHS England tell us that they sent us a letter in September, but even having seen the letter now, it wasn't terribly helpful and didn't really explain what was coming next. But definitely there was nothing within that about learning from the first 12 practices and what needs tweaking, whether. But the next thing we know is that they had told a load of practices and given just a 1 month notice of the change over the Christmas period. How balmy is that? To me, that means that these people have got absolutely no understanding or respect for how general practice works. The busiest period of the time, the period where we have lots of people off on holiday or sick, and 3 bank holidays. And to expect a practice to change a system that they have used for years, which is well embedded, and they've made work for themselves, within that time, not acceptable. So we fed this back to them, and then there was a meeting held recently with the NHS England lead for screening immunisation, who basically blamed it all on the LMC. And I wasn't there, but I've been told that actually that person was quite derogatory towards the LMC, and people at that meeting have told me that they felt that their behaviour was inappropriate and unprofessional. So why have we put this? So the first thing is to say this isn't something that we hadn't raised our concerns with. This isn't something that we hadn't actually discussed with them in advance about how it could be rolled out in a safer fashion, not to undermine practices, not to suddenly dump loads of workload, and not to potentially decrease vaccine uptake, at least in the short term. But that it was NHS England who just basically rolled ahead, disregarding what we said, disregarding what we had agreed in August, and then just the cherry on the cake, then blaming us afterwards. So if you've had any problems with this, if this has caused your practice any problems, please let us know. Please contact the LMC inquiries at llrlmc.co.uk. Please let us know about it.
Thanks, Grant. And I think obviously the outcome of that meeting, I think it's all around the communication, isn't it? Because I think that has been the kind of the challenge within this kind of area. And I think obviously the outcome of the meeting, that the practices felt like they were in a better position by the end, but unfortunately it had to get to that point to be in that position. So we just wanted to address that within here. Just going to move us on to the consent. Oh God, I wrote this in acronyms, so I've got to reread my acronyms that we did. So this is around consent for vaccinations for healthcare workers, and you had an S somewhere, so I don't know what the S spelled for, but
yeah, because it's healthcare support workers. So this isn't a new rule. This isn't actually a reinterpretation of previous regulations, but this is the UK HSA, the UK Health Security Agency, who of course used to be Public Health England. They have issued guidance, updated guidance regarding consent for vaccination by non-registered healthcare service workers, which they say is basically to just to explain in more detail what the position is and why. So this basically means that where a healthcare service worker is providing a vaccine under patient-specific direction, so they're not a registered healthcare professional, so they're unable to use a PGD, they're not a prescriber, then and of course that most of us are using sort of healthcare assistance to as part of our COVID and flu clinics. But where they're doing it, then the HCSW cannot gain consent themselves. So that consent must be done by a registered healthcare professional, so in essence a GP or nurse. Now, obviously, we've been thinking about, how can you mitigate for this? How can you make it easy? I mean, the first thing to say is that if it's a serious injection, so that includes the annual flu jab. So if someone's been consented for the flu jab before and it's just an annual flu jab, and the flu jab hasn't changed remarkably since the previous year, then that consent still holds. So all the healthcare social worker, healthcare support worker has to do is just to say to the patient, are you still happy for me to give this? And the patient gives their arm and you jab it in it, and that's absolutely fine. But for new patients, it is going to mean a little bit more thought. So either new patients, you'll have to, so patients who haven't had COVID or flu before, you'll need to ensure that they go to a prescriber or nurse working out of PGD. Or the other thing is that you can gain consent in advance remotely. Farine Danji, who's our deputy CEO, but also is the one of the local vaccination leads, has written a step-by-step guide to use Accurix to collect consent in advance. And we put that on a separate document. You can download it from our website. There is a link with the newsletter, or just search on the website and you should be able to find that. So just follow that, and that would allow, again, it would have to though come from a prescriber. So that message on Accurix would have to go out from in the name and with the and in effect from a GP or other prescriber within the practice.
Okay, so I think the advice is to kind of have a read of it. If there's any questions that come from it, and obviously come back to the LMC, and we'll be happy to kind of address those kind of things. So that kind of brings us to the end of our kind of main content in relation to the key points. We want to kind of move on to a bit of kind of more exciting kind of news now in relation to our upcoming AGM and our awards ceremony. Obviously, this is something that happens kind of every year. Do you want to take the... You can take the good bit if you want, Grant.
Absolutely. So, I mean, when I first arrived in Leicester, which was in 2016, I actually went to the first LMC AGM of that year, and there was about 4 people and a dog, and even the dog was looking confused about why they were there, and it sort of struck me as being a shame. Because this is an opportunity for the LMC to tell you what we've been doing on your behalf, and for you to tell us what we haven't been doing on your behalf or what we're getting wrong. And we will, it is also the AGM for the limited company, so we do have to tell you about all our finances, be open about them, what money we've had in, what we've spent it on, and what we've got left over. And so from that point of view, it's important, but I realise that doesn't get people to come along. Another aspect is that I've always been keen on what can we do to recognise the hard work and the people who go above and beyond within general practice, and that's a difficult thing to do. So as hopefully a few years ago, I was talking to Richard Mitchell about it at one of the UHL award ceremonies, because for several years they've asked me to be a judge at their award ceremony and to present prizes and what prizes mean. And he agreed. Actually, well, he offered. He said, "Well, how about we actually give an award to a GP each year?" And that's been good, but of course, that doesn't quite do it all. So last year, for the first time, we did an awards ceremony for GPs locally, and we had 3 criteria: outstanding contribution to general practice, greatest leader, and rising star. Now, we've agreed that this year we're going to do the same again. So we want your thinking hats on. We want you to look around you. We want you to spot people. Anyone working within general practice, doesn't have to be a GP, practice manager, a practice nurse, pharmacist, or healthcare assistant,
member of admin staff, anybody
member
really.
of admin staff, anyone that falls into one of those criteria, nominate them. So the closing date for nominations is Wednesday, the 11th of February. But the other, even more exciting thing is that last year, hopefully you know that we had for the first time, we had a real celebrity. I mean, in the past we have had people like Katie Bramwell Stainer come and Samira Anand. But last year we had when we had a true celebrity come and do a presentation, certain Adam Kane. And this year we have actually requested Phil Hammond to come. So Phil Hammond, for those who don't know him, trained as a GP in Birmingham, and I knew him from Birmingham. And sort of bumped into many different meetings, things over the years. But he trains a GP. He has been MD on Private Eye for many years. He was part of a comedy duo, Struck Off and Die, and in fact he's got a new series on BBC Radio 4 going on. He has written much stuff. He's done a lot of looking into various some cases. He was the first person to really highlight the Bristol scandal and the Letby case. At the moment, if you read his writings, you will actually think that maybe that was another huge miscarriage of justice, but time will probably tell on that one. So come and listen to him. Come and listen. He's going to give us a talk about his work, about his experiences, and then he's going to be presenting the awards. So come on and nominate someone so they can win the award and have a photo with Phil Hammond.
Thank you, Grant. For our listeners, we're actually not sat in the same room, and I think it's probably a good thing because I probably have jabbed him so many times by now. But it's all good. The just to kind of cover some kind of key dates in relation to what you've just said. Our AGM is on the 4th of March at the Marriott Hotel in the evening, and the nominations actually close on Wednesday, the 11th of February. So just to kind of give you those kind of deadlines for those opportunities, but it's all available in our newsletter. That kind of covers the most of kind of what we wanted to kind of give a bit of a kind of a snapshot recap on this newsletter today. Is there any kind of final thoughts? Don't give away your actual final thoughts, but is there any kind of final thought that you want to kind of add? I might just give a little bit of a plug in relation to we have actually been honoured to have Katie Bramwell come to the East Midlands on next Wednesday, which is the hold on. I'm kind of doing this off the whim. Grant, what's the date of it?
It's the
4th of February at the Crown Plaza. This is kind of takes away from the GPC webinars that have just happened. It's more of a kind of a direct kind of conversation. So it'll be a useful opportunity to kind of raise any questions. It's 7 p.m. at the Crown Plaza Hotel at the East Midlands Airport. We have a link on the website, so if you want to come. And just quickly, the other thing I wanted just to cover was around the GP job functionality within the LMC website. We know that it can be challenging out there for kind of GPs at the moment, but it is a kind of bank that we kind of regularly kind of get adverts from practices, and we're constantly kind of dating it. So it's free to advertise from LLR practices, and it's free for anybody looking to use it. And I think they were just the kind of the 2 points that I was going to cover. And I want to thank Grant for dragging me into this process. My face radio is as bad as my voice radio, so I hope people have found it useful.
Yeah, and please give us feedback because this is our first time by doing it by not as a single monologue by myself.
Yeah, not Charlotte again. We'll get Farine next time.
Yeah. So I am hoping that over time, actually, we might make it more of a discussion. More than maybe more than service, and develop it over time. But feedback as you think it's better or not as good. Feedback about how else we can improve it, how else we can make it more useful. Because the whole point is to provide something which is useful to you, the listener.
And for people that know me, I like a bit of banter, so I hope the ratings are lower than Grant's normal ones, because otherwise I will be destined to come back here again. So please don't listen.
I hope they
And
increase
if you got to
because
this
that's our
point,
point.
you definitely listened.
Okay. So on that note, I think we can both say farewell and catch up with you next month.
I hope you hit the record button, Grant.
Oh no.